An essential part of providing home health care is documentation. It provides us with an overall plan of care, specifics about how to carry out the plan, is a permanent record of what was done, by whom, and when, and is the means of ensuring payment for the services. It is important to understand that without proper documentation, payment can be refused by health care insurers, the federal government, the state, and the county. When the home health care provider is not paid for services given, then the employees of that agency cannot be paid. Who are the employees? You. You are also the people who are responsible for the proper documentation of the care. So your thoroughness in completing all appropriate forms is what ensures that you will be paid. As permanent records of care and services, these forms are also the legal documents utilized in cases of lawsuits. As legal documents, they must be accurate and true. Any falsification of records could result in your being fired from your job, or being brought up on legal charges in some instances. We will spend some time now taking a look at the care plan. This is the instruction sheet which outlines what should be done for the client. We will also look at the activity record, which is the form where you record what activity was done. Since the one tells you what to do and the other tells you what you did, these forms will be similar. They are filled out by different people, however. There are several different forms used for the care plan. One is the standard form used for clients where services are paid for by Medicaid and provided by CASA, the Community Alternative Systems Agency. Other forms are used for non-Medicaid clients and vary from agency to agency. They are similar, however, since they cover the types of activities provided by home health aides, personal care aides, and housekeepers. The Medicaid form is completed by a nurse from CASA following a complete assessment of the client's needs. It is posted at the client's home, so it is readily available for you to refer to. At the top, the client's name, address, and phone number are written. Next to that, you will find the days and hours of service and what type of employee will provide the service. In the box to the left, there is information about medications and special medical conditions. If additional information is necessary, a separate instruction sheet is attached. In the box on the right, there is a space for important names and phone numbers, which should be readily available to you and the client. The listings will vary according to the individual client. These include Emergency, Erie County Health Department or Visiting Nurses Association, the physician, caseworker, nurse, 2 places for a relative or friend who should be contacted if necessary, 2 places for provider agencies, and the transportation company if special arrangements have been made. Just below that is the type of transportation arranged for and whether an aide must accompany the client or not. The remainder of the form is for details of the care to be given. The time specific care is given is checked off in the first 3 columns, whether it be day, evening, or night. The 4th column is devoted to naming the activity, how often it should be done, special instructions, and if there are any restrictions regarding the activity. Let's look at a form which has been filled in so you can see some of the information you will be given on the care plan. The client's name is Martha Meadows, and she lives at 29 Schoolhouse Street in Anytown, New York. Her phone number is 716-555-0000. She is to receive care by a personal care aide, 3 days a week for 7 hours a day. This will be given Saturday, Tuesday, and Thursday, from 7 to 10 a.m. on the day shift and 3 to 7 p.m. on the evening shift. In the box entitled Special Observations and Precautions, you see that medication is to be prepared by the family member, and the aide is to remind the client when it is time to take it. Under special medical conditions, diabetes is checked. Looking at important phone numbers, emergency is listed as 911, which is standard throughout Erie County. You will note there is also a physician listed, the public health nurse, the daughter and son, the agency, and the number of a taxi cab company. The client is to travel by cab, and the aide is to accompany her. Moving down to instructions, a few things we see are that Martha is to have partial assistance with a sink bath on the day shift. Lotion is to be applied to her feet on both the day and evening shift. Any reddened or opened areas are to be reported to the nursing supervisor. Looking a little further down, we see that breakfast is to be prepared and served. Lunch is to be prepared for later use by the client, and dinner is to be prepared and served. On the day and evening shift, the dishes are to be washed, and the table, stove, sink, and countertop are to be cleaned afterwards. Near the bottom, we see that the family is responsible for grocery shopping, picking up prescriptions, and assisting the client in paying bills. Under Other, it is noted that the client goes to the foot doctor once a month, and the aide is to accompany her. The family is responsible for setting up the appointment and making arrangements for the cab. At the very bottom is the signature of the person who prepared the care plan and the date. As stated earlier, the format of the care plan for the non-Medicaid clients varies from agency to agency. It may be the same form used for Medicaid clients, or may be a form developed individually by the agency providing the care. The name of the form also varies. It may be referred to as the care plan, instruction sheet, worksheet, or something else. To avoid confusion, we will call the form which is posted at the client's home the instruction sheet. This instruction sheet is generally completed by the supervising nurse from the agency who visits the client before care and services actually begin. It includes the client's name and address and other identifying information. It would also include the type of personnel who are to provide the care to be given, including what shifts the activities are to be performed, how often they are to be done, the amount of help needed, and specific directions where necessary. Some activities listed include bathing, mouth care, hair care, grooming nails and shaving, eating and preparing meals, dressing, ambulation, transfer, and range of motion exercises, skin care, and housekeeping. Usually at the bottom you will find the signature of the person preparing the instruction sheet and the date it was prepared. There may also be spaces for documentation of review. Generally, care plans are discussed with you before you begin taking care of a client. This may be before you go to the client's house or on the first day of work with the client. Now the job begins, and documentation of what is actually being done for the client is recorded. All caregivers have the responsibility of documenting what they did for the client during the hours they were with them. This is done on the activity record, worksheet, or whatever your agency calls it. It is very similar to the instruction sheet, except it gives you a place to check off what you have done for the client during a one-week period. Some agencies ask you to use a check mark, while others ask you to initial the space. Your agency will tell you which they prefer. At the top of the record, there is a place for the client's name, address, and sometimes a client ID number. There is also a place for your name and maybe your Social Security number or employee number. Some agencies also ask for the week ending date, which is the last day of a pay period. For example, if the pay period runs from a Saturday to the following Friday, you are paid for the work starting on the Saturday and ending that next Friday. The week ending date would be that Friday. There is a separate section for you to write in the visit date, the time you arrived, the time you left, and the total hours for that day. This is done for each day you work. In this example, you can see that the aide worked from 7 to 10 a.m. on Saturday, February 3rd, Tuesday, February 6th, and Thursday, February 8th, for a total of 3 hours each day. The week ending date for this pay period would be February 9, 1990. Some agencies use this section of the activity record as your time slip also, so there may be additional information asked for. There is also a place for your signature and the signature of the client. For agencies which do not combine the time slip with the activity record, a separate time slip is filled out and attached to the activity record. The information on the time slip and activity record relates only to the individual being cared for. In either case, both the activity record and time slip must be sent to the agency at the end of the work week in order for you to receive payment for your work. Sending one without the other will delay payment. The agency, in turn, must submit the activity record in order to receive payment for the services they have provided. Before we look at how to fill out the rest of the activity record, we should take a look at the instruction sheet and see what you are supposed to do for the client. Let's look at Martha Meadows' instruction sheet again. Suppose you are the aide assigned to her for the day shift. All the activities marked with an X in the day column are to be done by you. You have just finished your shift for Saturday, February 3rd. It is the first day of the pay week, so you must fill in the top of the activity record, starting with the client's name and address, the week ending date, which would be Friday, February 9th, your name and title, the visit date, the time you arrived, the time you left, and the total hours for the day. Next, you would check off what you did for the client and make notes where appropriate. Let's see how this works. You helped the client with a partial bath at the sink, and then soaked her feet. Suppose today was the day the client went to the foot doctor, and you did not soak her feet. They did it there, however. In this case, you would not check the box, but would note that it was done by the doctor. You also put lotion on both feet after soaking. If you had noticed any redness or swelling, you would have called the nursing supervisor to let her know, and you would have noted on the activity record that you called her about it. You helped the client clean her dentures, brushed her hair, and assisted her in dressing. You also assisted in toileting and using the walkerette for walking. You did reality orientation by talking with Martha about her children and discussing something you both saw on television that day. You prepared breakfast and served it, and made lunch for her to eat later on. You dusted but did not vacuum because the vacuum was broken. You left a note for the family about it and documented this under comments on the activity record. You cleaned up the kitchen after making breakfast and lunch by doing the dishes and wiping off the table, stove, and counter. You also did some hand washing, but there was no mending to do. The family took care of getting groceries and prescriptions and helped Martha to pay bills. You reminded her to take the medication the family had pre-measured and put in a cup labeled with the time the medication was to be taken. If the family had not pre-measured the medication, you would have to call your supervisor and put a note on the activity record about it. This was not the day the client was scheduled for the doctor's appointment, so nothing would be recorded in this space. If it had been scheduled, then you would check other and write in went with client to foot doctor. If there is ever a time when the client refuses to do one of the activities that is checked on the instruction sheet, you should write client refused instead of checking the box. If the client repeatedly refuses, be sure to notify your supervisor. At the bottom of the page, both you and the client would sign the sheet for Saturday. The activity record should be filled out at the end of every day you work with the client. At the end of the week, return the completed activity record and the timesheet to your agency. Be sure that both forms have been signed by you and your client. As was mentioned before, the time slip and activity record must be sent in together in order for you to get paid for the week. Before you send the two forms in, you should make sure that they have been filled in completely and correctly. Compare the dates, times, and total hours. Compare the instruction sheet and the activity record. If there are things that were not done, be sure to explain why. Never check anything which you do not actually do. This is falsification of records and could lead to your being fired or brought up on legal charges. The care of the client is routinely reviewed through home visits by nursing personnel from the county or other referring agencies, plus your nursing supervisor. If you are supposed to bathe the client, but they consistently find that she is dirty when they come to see her, they will question your care. They will review the activity records to see if you say you are bathing the client. If you are not, they will want to know why. If you say you are, then you will probably be asked to return to the agency for counseling and re-instruction in proper bathing techniques. Documentation is an essential part of providing home health care, and you are an important link in ensuring that it is given and that payment is received. Become familiar with the care plan so you will give all the care that is needed by the client. Fill in the activity record and time slip completely and accurately. Be sure they are signed by you and the client. Return both forms together promptly at the end of the work week if you want to get paid promptly. If there is a problem in completing the activities assigned to you, do not hesitate to call your supervisor. We aim to give quality home health care to our clients, but without proper documentation, we could be prevented from doing that. Please, do your part. Dealing with people is an ever-changing experience. Our moods vary from day to day, as do those of the people we come in contact with. As healthcare providers, you work with a group of people who are especially susceptible to things which may make their moods less than what you would hope. Sometimes these people become difficult to work with, and they become abusive or refuse to cooperate. In order for you to be effective in working under these conditions, you need to have an understanding of what makes people abusive and uncooperative. Once you have an understanding of why people react as they do, then you can learn what to do to improve the situation. People who receive home health care are generally people who have become increasingly dependent on others because of illness, accident, or age. This can be a very frustrating and depressing time for these people. They become anxious about their future, lose their self-esteem, and may become very angry, jealous, and resentful of others. They may just not feel well. This can make any of us cranky at times. Being disabled or getting older gives them a feeling of uselessness or lack of purpose. This feeling is not uncommon in the elderly, as they no longer have families to care for. They are retired and less active outside their homes, and they are losing their ability to care for themselves. Also common to the elderly is their distrust of the unknown. You, for instance. You are going into their homes and asking to do things for them which they used to do themselves. At other times, you are asking them to do things to help themselves, which they think you should do. After all, you're being paid to be there.
Aren't you supposed to do this?
Oh, I don't always do it. You know, you helped me make sandwiches last week. Here you go.
The wrong approach when you start working with a client, or during those visits when he or she is in a poor mood, can result in the client becoming difficult to deal with. In some cases, no matter what you do, you will not be able to make the client more cooperative. In this case, your best bet is to call your supervisor and ask for help. In most cases, however, you can work with the client and improve the situation. How do you do this? The key lies in your understanding of why they are irritated and in your approach to the situation. Understanding comes from your taking the time to become familiar with the reasons we have just finished discussing, and then watching your clients and listening to them to see why they are behaving as they are. Your approach then becomes a response to the reasons for their behavior. Your responses should be designed to reduce or eliminate those things which are causing the problem. Your attempts may not always be successful, but if you don't try, you will probably make the situation worse. Now let's take a look at approaches you should use to help your client be more at ease with you right from the start. From the very moment a client meets you, you are making an impression on the client which may help you or hinder you as you care for the client. This impression about you is formed from a combination of the mood the client is in before you come and how you communicate with the client after you get there. Communication has many aspects to it. When you speak, you can say it politely, rudely, impatiently, excitedly, with great disgust, or an unlimited number of other ways. Your tone of voice gives the client a clue as to how you feel about the situation. Listen to these responses.
I'm very angry.
What did I do? I didn't do anything.
Oh, I'm so concerned. Hey, listen, I don't care what you do.
Each of these tells you exactly the feeling behind what is said. Anger in the first one, concern in the second, and not caring in the third. These same feelings can be said in different words through tone of voice. Listen.
Oh, will you give me that? I'll do it myself. Hey, I'm sure you'll feel better after you rest a little. Here's your lunch. Eat it if you want.
In these last three examples, the same feelings were expressed, but you couldn't tell it from the words, only the way they were said. If you were not talking face-to-face with the client, then only the tone of voice would be important. But when you are face-to-face, then the expression on your face also reflects your feelings. Here you see anger. Here is what you look like when you're ready for a fight. And here is what real caring looks like. The client not only looks at your face when you talk, but also at the rest of your body. When you're bored with your job, you may look like this. When you make a decision and you won't listen to any compromise, you might find yourself looking like this. When you're really worried, this could be how you look. Of course, communication is a two-way street. Just as the client can see what you are feeling from your tone of voice, facial expressions, and body posture, so you can see what the client is feeling.
Okay, I'll buy a couple of
These are important for you to observe in the client, so you can begin to understand behavior and what type of approach to take.
I have to get back, and we have all these other things I have to do for you, all right?
Well, you're supposed to help me.
I am going to help you.
Well,
You're not shopping yourself, are you?
Yeah, but I think I should be able to, I'm paying for the food, I should be able to pick out what I want.
Well, don't worry. I think I know what you like. I mean, you look like you like everything anyway, so don't worry about it, okay?
Obviously, this aide did not take the time to pay attention to the client's response to her approach, and all it did was make him very angry. Quality home care is so dependent on communication between the client and the helper that you should take time to practice.
Well, it's hard to get around with
Look
my
at
knee.
people you see throughout a day and see if you can determine their mood by how you see them communicating with others.
She always kept the place real clean.
Listen to yourself when you talk with other people in different situations. What are you saying?
Can we get this straightened
How
out?
do you say it?
Just take a second.
What does your face feel like? What is your posture?
Oh, that goes in the drawer over there.
Okay, good.
We mentioned first impressions before, and that is the key to developing a good relationship with your client. We would like to have you watch some examples of different approaches used on a first visit with a client. After each, we will discuss the approach and how effective it was.
I wonder where that new girl is. This is ridiculous needing help at my age. If it wasn't for that accident, I wouldn't have problems with this knee, and Linda would be here with me. Look at this house. It was never a mess when Linda was alive. I can't believe that she's been gone for 3 months already. I hope the aide gets along with me. I feel trapped in this house, and I don't want to be trapped with some bossy woman. Who are you?
It's your aide. Open the door. It's cold out here.
How do I know who you are? Where are you from?
Brother, look. It's Sue Sampson from All Out Healthcare. You knew I was coming. Open the door. Jeepers. Freezing. It took you long enough. Jeez.
You can come in, but don't expect to stay.
Don't stay long.
I don't need your help. I can do it myself.
Here you have seen a client who showed several different feelings before the aide came. He was nervous and fidgety, waiting for the new aide to come to the house. He was angry about the accident and mad at himself for needing help. He was also depressed over the loss of his wife. His feelings were easy for us to see. Of course, we had the benefit of seeing the client before the aide and hearing his thoughts. Now the aide arrives. Before she had even met the client, she demanded that the client open the door and sounded pretty irritated about having to wait. The aide was even more irritated when the client still didn't open the door, but questioned her about where she was from. When the client finally opened the door, the aide was very rude. What's your first impression of the aide? Not very good, I'm sure. What did you notice about the client's mood as the scene progressed? The client was nervous as he waited for the aide. He appeared to be the type of person who would be cooperative if handled right, but could easily become uncooperative if pushed. By the time the aide was in the house, the client was no longer nervous, but rather angry and unwilling to cooperate. His first impression of the aide was that she certainly wasn't someone he wanted to be trapped with. Obviously, the aide did not take the right approach. She created an uncooperative client. Now, let's look at the same scene, but with a different approach.
I wonder what Mr. Jennings is like. Well, he's probably not real happy about having to get help. He's not that old. It's probably been hard for him, losing his wife so young and then being laid up with his knee ever since the accident.
Who's there?
Mr. Jennings, it's Sue Sampson, your aide from All Out Healthcare.
Please, come in.
Thank you. Can I help you?
No, I'm fine.
Okay.
Now we see an aide who has thought about the client before they meet. She realized that the client would probably feel funny about needing help, and that the loss of his wife and freedom to get around because of the knee injury could make him a little difficult at first. She patiently waited for Mr. Jennings to answer the door, assuming that he may not move very quickly because of his knee. She showed respect for the client by addressing him as Mr. Jennings, and made sure she identified herself appropriately. Commenting positively about the house helped put the client at ease. She was sympathetic about his loss, but did not dwell on it.
You know, the accident.
She gave him hope and encouragement by focusing on how she could help him with household burdens, so he could concentrate on getting better. What is your first impression of the aide now?
Sounds great.
I'm sure it's much better.
Why don't you call me Larry?
What about the client? His nervousness seemed to subside very quickly once he met Sue, and the start of a friendly relationship appeared to have begun.
You said you're coming in.
His first impression was that Sue appeared to be someone he could work with,
Cheerios.
and maybe, with her help, he could soon be better. As you can see, first impressions are important. Here are some additional tips to help you make a good first impression. Be prepared. Think about clients before you meet them. How would you feel if you were in their place? Try to understand what they might be feeling. Your appearance is important in making a first impression also. Feel good about yourself. Be neat and clean, and don't wear excessive jewelry, makeup, or perfumes. Offer your hand or just gently touch the client's arm or shoulder. Some people feel comfortable shaking a person's hand. Others do not. This is especially true with older people. It is totally individual, so you'll have to be sensitive to how your client responds. Take the time to let your client get used to you. Sit down and talk together for a while so you can get to know a little bit about each other. Look over the care plan, and then plan your day together. Make sure the client understands you. Talk only as loudly and as slowly as necessary for the client to understand. You do not have to talk loud just because a person is elderly. Repeat things if necessary, and use different words if the meaning is still not clear. Remember, be warm and courteous. Show you care, and take the time to establish a good relationship with the client before you start working. Just as important as the first impression is the ability to keep the good working relationship going. This again depends on how you approach the client through communication. You want to show acceptance of the client as an individual. It is important that clients feel liked and accepted by you. If a client feels that you do not like him or her, then that person will feel uncomfortable with you and will begin to respond negatively to you. This negative attitude could spill over onto your coworkers who also come in contact with the client. Here again, you show acceptance not only by what you say, but also by your actions.
Then I'll just get plain, and then we'll add our own sweetener.
Okay,
Right?
okay.
Okay, good.
I'm sorry the place is such a mess. Let me...
Hey, don't worry about it. Look, you've done a fine job under the circumstances.
Well, it's hard to get around with my knee.
I understand. Look, this looks just little pickup things.
Well, yeah, but my wife, she always kept the place real clean, real nice.
And I'm sure she'll be very proud of you right now. Don't worry about it.
Well, can we do this? Can we get this
Sure.
straightened up?
Sure, this'll just take a second.
All right.
Where does this go?
That goes in the drawer over there.
Okay, good, good.
What types of actions convey acceptance? Looking directly into a person's eyes when you are talking does. In most cases, not doing so makes people feel like you may be lying, that you are not sincere, or that you just can't stand looking at them. Paying attention to what a client is saying and really listening also helps. This will also improve a client's self-image and shows that you care about that person as an individual. When you gently touch your client on the arm or shoulder, you also convey acceptance. It makes people feel that you really care about them. Being relaxed and comfortable around the client also helps. Clients will sense that you like them and accept them when this is done. They in turn will also feel more comfortable with you and be more cooperative. The words you are saying also convey the feeling of being liked and accepted. Using a client's full name shows respect. If clients ask you to use their first name, you should if it makes them feel more comfortable. Avoid saying things which make people feel that you disapprove of them or what they are doing. When Sue came into Mr. Jennings' house, she didn't look at the house and say, "What a mess this is." If she had, the client would have immediately tensed because of the disapproval. Instead, she was understanding of the situation when the client pointed out that the house was a mess and offered to help to improve it. She also complimented him so he felt better about himself. She told him what a fine job he had done even under the circumstances. Be careful with compliments, however. They should always be said with real sincerity, not just because it's the thing to say. A client will know when you are not telling the truth. One last thing you can do to show acceptance is by asking for the advice or opinion of the client on matters pertaining to the client's care. Let them feel that what they think counts. Here again, ask this in all sincerity and follow through on their recommendations as much as possible. If you are not planning on seriously considering their recommendations, don't ask. It will just make the situation worse. While you are developing a good relationship with your client, it is important to remember that you want to be building a helping relationship. You do not want to make the client become totally dependent on you. Let's watch the following skit to see some examples of how to build a helping relationship.
I thought I'd make you some homemade soup from the leftovers in the refrigerator.
What's in there?
I think I saw some chicken and a lean piece of ham.
Ham!
And
You know, my wife used to make this great soup out of
Oh,
leftover
really?
ham. And she'd put in, let's see, chicken broth, onions, potatoes, spinach, and cheddar cheese.
Ooh, it sounds
You
delicious.
think you could make that?
Oh, I think so. Well, not as good as she did, probably, but I'll give it a try. Hey, look, I haven't gone grocery shopping yet, so if you write down what we need, I'll be sure to pick it up, okay? And I'll finish cleaning up in the kitchen.
All right.
Oh, and then when I come back, if you want to, you can help me with it.
Okay.
Hey, how are you with the potato peeler?
Well, not very good, but I'll give it a try.
Okay.
Some very interesting things were happening in this skit, which were effective in building a helping relationship. Sue decided to make some homemade soup and told Larry what she was planning. She also took the time to ask Larry what he liked. She listened with interest as he talked about how his wife used to make a spinach soup and was willing to give it a try. She encouraged independence and participation by having Larry do the shopping list while she finished up in the kitchen. She further encouraged it by suggesting he be included in the preparation. Being able to joke about Larry's ability with a potato peeler indicates that a very easy and comfortable helping relationship has developed. If you think back to our first skit where Sue started off on the wrong foot, do you think that this type of relationship would have developed? I doubt it. Just a few additional tips for developing a helping relationship. Always listen carefully and be patient. Sometimes stories can become a little long. In that case, see if the story can be continued while you do one of your chores. Be careful, though, if you do that. Be sure you are still remaining attentive to what is being said. Sometimes your client or the client's family tries to involve you in family problems. Show a genuine interest in the family, but don't get involved. You are there to help the client, not to become a part of the family. If your client makes a mistake, or something happens that shouldn't, don't blame the client if it can't be helped. This will only make the relationship get worse instead of better. If the situation makes you start to lose control, stop. Call your supervisor and ask for help. By this time, you should have a good idea of how to avoid making a client a difficult person to deal with. First of all, you must take the time to understand why a client is behaving as he is. Is the client depressed, angry, frustrated, feeling useless or without purpose, or just not feeling well? Try to find out the reason. Do not take their actions personally unless you are the cause of them. If you are using good communication skills, you will not be the cause. What are these skills? Making a good first impression, showing that you like and accept the client as an individual, building a helping relationship through caring, and being sincere, honest, patient, and respectful. In summary, then, dealing with other people is an ever-changing experience. Moods vary from day to day for you and for those who you come in contact with. As a healthcare provider, you want to do everything you can to understand these moods and use your communication skills the best you can to develop and keep a good working relationship with your clients. The majority of the time this works. People respond to caring, honesty, and patience. On occasion, however, it doesn't work, no matter what you do.
I'm going to call your office.
For your sake and that of your clients, don't get angry. Call your supervisor and ask for help. Caring for other people should be an enjoyable and rewarding experience.
Oh, and then when I come back, if you want to, you can help me with it.
Okay.
How are you with the potato peel?
Well, not very good, but I'll give it a try.
Okay.
Everyone has the right to privacy. What people tell others about themselves is up to them, not anyone else. As healthcare providers, you are frequently given information about people which is confidential, but necessary for you to know because of the care you give. For example, the client has a very serious weakening in the wall of one of his major blood vessels, which could break open at any time and result in death. You need to know this information so that you do not permit the client to do a lot of bending or lifting. But it is confidential information and nobody else's business. If you pass this information on to other people, it may be an invasion of that person's right to privacy. This holds true for any information you know about a client. With the growing number of people having AIDS, special laws have been written to protect the rights of these people to privacy and confidentiality. The law is called the New York State HIV Confidentiality Law, and it affects you. To help you understand this law better, We will first briefly summarize the law, define a few terms used in it, discuss how the confidential information is released, and then look specifically at release to healthcare providers and what this means to you. The law says that any person who has an HIV infection, HIV-related illness, AIDS, or is to be tested or has been tested for any of these, has the right to be protected under the HIV Confidentiality law. HIV-related information is considered confidential. The protected person has the right to allow only those people he or she chooses to be given this confidential information, except for certain people whom the law specifically identifies. Now let's try to define some of the terms above to help you further understand this law. What is HIV? HIV stands for Human Immunodeficiency Virus. Infections which result from this virus are known as HIV infections. Illnesses associated with this infection are HIV-related illnesses. Tests which are performed to check for the presence of an HIV infection are called HIV-related tests. All of this information is considered confidential HIV-related information. Also classified as being confidential is any information which may identify an individual as having any of these conditions, including information about the individual's contacts. Contacts include the spouse or sex partner of the protected person, or a person identified as having shared hypodermic needles or syringes with the individual having an HIV-related problem. The human immunodeficiency virus has been identified as the probable cause of AIDS. What is AIDS? AIDS is the acquired immune deficiency syndrome. This is a condition which reduces the ability of a person to fight disease and infection. It opens them up to all sorts of infections which normally are not a threat to healthy people, but can be fatal to people with AIDS. There are very specific rules about the release of confidential HIV-related information. These rules are divided into two parts. The first part deals with the client's right to identify those people who may be given the information. If that person is unable to give consent, a person who has been chosen by the court to sign for the client may do so. For a child, this person is usually the guardian parent.
This is a confidentiality.
Before any information can be given out, the client must be given an authorization for release of confidential HIV-related information form. It is on this form that the person identifies who is being allowed to release information. It also contains the name of the person who will be allowed to receive the information, the reason the information may be given, and how long the release agreement is in effect. There is also space on the form to put the client's name and address, and that of the person legally allowed to sign for the client if the client cannot do it for himself. The client does not have to allow information to be released and can change his or her mind at any time, even if an agreement has been signed. The second part deals with who can receive this information without written consent of the protected person. Guidelines in the HIV confidentiality law define this very specifically. On the back of the form is a list of people identified as being able to receive the information without consent. You will note that C identifies healthcare providers as being able to receive this information, but only to those who reasonably need the information to supervise, monitor, or administer a health service. The protected person has the right to know if any information has been given to these people. If you receive confidential HIV information, it does not give you the right to pass this information on to anyone else unless they come under the definition as seen on the back of the release form. Giving this information to people who are not authorized to receive it is in violation of the law and can result in a fine or a jail sentence or both. The only exception to this is your continued responsibility to immediately report anything to your supervisor which may jeopardize the well-being of children or adults in the household of the client. For example, child abuse. Since there is a lot to understand within this law as to who can receive this information, the safest thing for you to do is to only give the information to your supervisor and let that person pass it on if appropriate. Your employer has written policies and procedures designed to maintain the confidentiality of that HIV information. It is your responsibility to read and understand them. You are required to read them when you first start work at the agency, and then attend an in-service on HIV confidentiality at least once a year. If you do not do this, you cannot be authorized to receive the confidential information. Failure to be familiar with these policies and procedures does not give you a legal excuse if you are ever brought up on charges for disclosing information to unauthorized people. You should understand that gossiping among your coworkers is considered to be releasing confidential information without permission. Discussion of the client with a coworker directly involved with the care of the client is appropriate, but only if it is necessary for the care of the client and they have appropriate authorization to receive that information. Here again, it is best to give any other information which you are not sure about to your supervisor and let that person pass it on if appropriate. Part of the policies will include a list by job title of employees able to be told HIV confidential information and what the limitations are in being allowed to have that information. The degree of access is determined by how much you need to know to perform your duties. For example, the Director of Nursing may have full access to ensure appropriate patient care and personnel supervision, while the Administrator may have access limited only to that information necessary to make decisions about equipment, supplies, and personnel allocations, or to ensure appropriate billing and reimbursement. The receptionist may have no access, while the bookkeeping clerk may have limited access for billing. Nursing and aid personnel may have access limited to information necessary to provide appropriate care to the patient or to the patient's child. Just because you are taking care of a person with an HIV infection does not mean that this information has to be passed on to you. This is true of any information whether you are caring for a client with an HIV problem or any other condition. In any case, information is not provided solely for the purpose of infection control beyond normal precautions. If you normally wear gloves to clean up soiled linens, then you don't need to know that an individual has an HIV infection and that blood in the stool can transmit the virus to you. You take the precaution routinely, irregardless of the diagnosis of the client, so you don't need to know the specific confidential HIV information. It is only provided if you are at significant risk of getting the infection as a result of the duties you perform while caring for the person. You may be at significant risk if you are exposed to the body substances which can transmit the infection. These include blood, semen, vaginal secretions, breast milk, tissue, and body fluids including cerebrospinal, amniotic, peritoneal, synovial, pericardial, and pleural fluids. In home care, you would normally not be exposed to any of these substances except possibly blood, vaginal secretions, and amniotic fluid if your client happens to give birth while you were there. Circumstances which do not involve significant risk include exposure to urine, bowel movements, sputum, nasal secretions, saliva, sweat, tears, or vomitus which does not contain blood that you can see. Human bites where there is no direct blood-to-blood or blood to mucous membrane contact also are not significant. Of course, if your client has bleeding gums and bites you hard enough to draw blood, then you should be concerned. Exposure of intact skin, free of sores, dermatitis, or scratches to blood and other substances is also not significant. In procedures where you normally wear protective barriers, such as gloves, then you also are not at significant risk. So you see, the degree of risk of exposure to the virus determines the degree of access you have to confidential HIV information, and in home health care, that risk is small. In summary, the New York State HIV Confidentiality law protects the rights of people with HIV infections, HIV-related illnesses, and those who are being or have been tested for these conditions. It gives them the right to control who gets information about their condition and the means to do it. It defines exceptions for those others, such as healthcare providers, who are identified by law to receive the information, but puts restrictions on them according to their need to know the confidential information in relation to the performance of their duties. And lastly, it defines what significant risk is, so that access to information can be limited to only what is needed. In home care, the risk of contracting an HIV infection is very limited, so the information provided to caregivers is also very limited. But if you do receive confidential HIV information, remember that information is confidential and not for you to pass on to anyone you want to tell it to. Also remember, this is not only true of information about clients with HIV problems, but also about any information you have for any client. If you have any questions, ask your supervisor. When we become responsible for the care of other people, we also take on the responsibility of ensuring that their individual rights are protected while under our care. This responsibility not only belongs to the agency providing health care in the home, but also to every person working for the agency. During the next few minutes, we would like to familiarize you with clients' rights as they are defined by New York State law. This will help you have a better understanding of what the agency has to do and what you have to do to make sure that these rights are not violated. The agency has 3 responsibilities. 1, make the staff aware of clients' rights and help them to understand these rights. 2, make the client aware of their rights. And 3, do certain things which will help ensure that agency policies and procedures protect the rights of the client. To make the staff aware of clients' rights and any changes which take place, the agency must instruct all new employees about these rights. To help clients become aware of their rights, the agency must provide the client with a written copy of the rights at the time service begins. This must be documented in the client's record. The agency must also provide them with a statement of the services which are available and the charges for those services. And lastly, the agency must explain how the client can make a complaint about care and services if not satisfied with how they are given. If the client has a person appointed to act on his or her behalf, then this information is given to that person along with the client. To ensure the client's rights are protected, the agency must have written policies and procedures which outline the operation of the agency and how services are given and duties performed. For example, there must be specific policies and procedures for the storage, cleaning, and disinfection of medical supplies, equipment, and appliances. There must be documentation of all care and services given. Whenever possible, the client should receive care from the same personnel on a regular basis, rather than different people all the time. And the agency must provide all employees with proper and current photo identification. Whether you are a direct caregiver, such as an aide or nurse, or a support person working in a clerical or administrative position, you have two responsibilities. One, you must take the time to learn and understand what clients' rights are. And two, you must conduct yourself in such a manner that you ensure the rights of the clients are protected. Let's take a look at some of these rights and discuss them a little further. Besides being informed about their rights, services available, and how much they cost, and how to file a complaint if they are not satisfied, clients also have the right to participate in developing their plan of care and their discharge plan. They also must be informed of all treatments provided by the agency, when and how services will be performed, and the name and function of all people and agencies which will be providing the care or services. The following is a scene which takes place in a client's home. The nursing supervisor is discussing the care plan with the aide.
Mrs. Rose, Jenny will be taking care of you during the day. Now, here's what you have to do for her. You can make out your schedule anyhow you want.
Will she be giving me a bath?
Yes, when she has time.
I think I'll give her a bath first thing in the morning. That way I'll have the hardest job out of the way.
But I don't like to take my bath right away. I'm always hungry when I get up and I like to eat right away.
But it's easier for me if I give you your bath before you eat.
But it tires me out so much I can't eat.
Well, I still think I'll give her a bath first.
What else are you going to do to me?
You'll see.
Was the client being given her rights to participate and be informed in this skit? No. The nurse and aide tended to talk between themselves, and whenever the client tried to have some input into the care, it was disregarded. Although Jenny was introduced by name, she did not have an identification badge on, so the client could not tell if she was another nurse, an aide, or just who she was and where she came from. When the client wanted to know what else Jenny was going to do, her question was put off with a simple, "You'll see." Let's rerun it and see if we can do it right.
Hi, Mrs. Rose. This is Jenny Thompson. She's a home health aide. She works with me at the agency. Now, she's going to be here to help you with your meals, your bath, and some light housekeeping.
Well, hello, Jenny. I sure could use some help. Could she be able to wash out a few things for me? I can't do it for myself anymore.
Oh, I think so. Here, well, look here and see what we have planned for you and see if it's all right with you.
I'll be helping you with your bath. Do you like to have it before or after you eat in the morning?
Oh, after. I'm always hungry when I get up, so I like to eat right away. If I take my bath first, I'm so tired, I can't eat, even if I'm hungry.
Oh, I don't see any problem with that. I'll help you wash your hands and face to freshen up a bit, and then we'll do the bath after you finish eating.
Oh, that will be good. I was worried you wouldn't let me do that. Now, what else will you help me with?
Well, she could clean up the breakfast dishes for you, and if you have any clothes that need cleaning and washing out, she can wash them out for you.
Quite a difference. The client was included in planning, knew who was going to take care of her, and was pleased rather than dejected as she was in the first scene. There was a visible difference in the client and the relationship that was developing between the two. In the first skit, the client said, "What else are you going to do to me?" While in the second skit, she said, "What else will you help me with?" In the first, they were working against each other. In the second, they were working together. This is what you want for the benefit of your client and yourself. Several other rights the clients have are to be treated with consideration, respect, and recognition of their dignity and individuality, and the right to refuse treatment if they want to, after having been told the effect this may have on them. The following scene will show how not to treat a client.
Here's the cup of pills you're supposed to take. Now hurry up and take them so I can get back to what I was doing.
But I don't want to take those pills. They give me an upset stomach.
Oh, stomach schmummick. You always have something to complain about. I sometimes think you lie awake nights thinking of things to complain about.
But they really do upset my stomach.
Look, my orders are to give you this cup of pills. If I don't, I could lose my job. That would make you happy, wouldn't it? Now take them.
Let's redo that scene. I'm sure there is a lot better way to handle the situation.
Here, Mary, here's the cup of pills you're supposed to take now.
I don't want to take those pills. They always give me an upset stomach.
But it is important that you take them. Otherwise, you could start having trouble again.
But I feel worse after I take them.
Have you told your doctor about this?
No.
Why don't I call my supervisor and tell her the problem? Maybe there is something different your doctor can do for you.
Would you do that? I'd appreciate it.
Sure I could.
Thank you.
That's better. Now the client is being treated with consideration. She is briefly told of the possible consequences if she does not take her medicine, and her concerns are being respected. The aide offers her a possible solution by calling her supervisor. Of course, this is something which should be done anyway if a client refuses medication. Another right clients have is the right to complain about care or service given to them.
Hello? Yeah. Yes, this is Mrs. Rose. I want to make a complaint. I mean, I have an aide that comes in here every day and is so rude to me and does not help me.
They should
Now,
be able to make complaint
I need
without any
help
interference,
with that.
discrimination,
And she
or
doesn't
threats
help.
from the people
I mean, I
or
would
agency
fall.
being complained about.
Well,
Clients should not
understand
have to
that,
fear
but I
that
do
something
think
will
that you
happen
could
to
be a
them
little
if they make a
more courteous and
complaint.
helpful.
They can also make recommendations for change in the policies and procedures which have resulted in the complaint. Complaints and recommendations can be made to agency staff, the New York State Health Department, or any outside representative the client chooses. The agency has the responsibility to investigate any complaints and respond to them. The last right deals with privacy and confidentiality, including client records. Let's look at a situation you may run into.
I'm worried about my tenant, Mrs. Rose. I know you have people going into work with her. I was wondering, is it safe for her to be alone?
Let me see what the nurse says. I don't think there should be a problem according to this.
Well, I hope not. I worry because of my insurance. Suppose she starts a fire or something.
Here you have a neighbor coming into the agency and asking about the client. Confidential records were shown to the person without any authorization from the client. Even though the neighbor had legitimate concern, he has no right to this information without the client's consent. Here is what the coordinator should have done.
I'm worried about my tenant, Mrs. Rose. I know you have people going into work with her. But I was wondering, is it safe for her to be alone?
Well, I'm not really free to discuss Mrs. Rose's situation. If you'd like me to call her, or why don't you talk to her?
Well, maybe. I mean, I'm worried. I'm worried about my insurance. I mean, she could start a fire or something.
Why don't you talk to her then?
All right, I'll do that. Thanks.
It's nice to be helpful when someone shows a real concern about another person, but discussing the client with an unauthorized person without permission from that client is a violation of the client's right to privacy and confidentiality. The only times information can be released without client permission are to a healthcare facility where a client is being transferred, or for third-party payment. As residents of Erie County, clients have some other rights which expand on those specified by New York State. Clients have the right to choose the agency which will provide care for them. They also have the right to a written statement of the name of the person supervising their care and how that person can be contacted. They must be informed of the name of any replacement employee when the regular person is unable to come. All agency personnel must have photo IDs. Without them, clients can refuse to admit them into their homes. Care plans must be posted in a client's home where they are easy for the client to read. Clients have the right to see their clinical records and should be given a copy of the policy which explains how this can be done. Complaints about care and service can also be made to Erie County. The agency must provide the client with the names and numbers of places to contact in case of a grievance. These include the agency representative or the county CASA case manager and the county home health review. Whenever rights are given to people, there are also responsibilities to go along with those rights. We've talked about the agency's responsibilities in ensuring that these rights are protected, and also your responsibilities. What about clients? They have responsibilities too. Clients should be courteous and considerate of the people caring for them, and not discriminate against them because of race, color, sex, age, or national origin. They should be cooperative in planning and carrying out reasonable recommendations made by their physician, nurse, case manager, and other healthcare staff. They should provide necessary information to the planners and caregivers so that quality care can be given. Valuables should be kept in a secure place. And lastly, clients should sign timesheets for the actual hours worked and notify the agency if their caregiver does not come when scheduled.
Well, I've been waiting a half an hour.
Over the past few minutes, we have demonstrated or told you about the rights clients have when receiving home health care. We have also looked at the responsibilities the agency has in ensuring clients' rights are protected, your responsibilities, and the client's responsibilities. A copy of the rights is available through your agency. You should review this and become familiar with it. If a complaint is filed against you, you are responsible for knowing these rights. Not knowing them is not accepted as an excuse. Be sure to take the time to learn them and abide by them. Germs have a way of spreading right before our eyes, even though most of them we cannot see. During the next few minutes, we would like to take a look at just what germs are, how they are spread, and how to go about stopping them from spreading. First of all, let's define what germs are. They are any small bit of living matter which is able to develop into a new individual. Some we enjoy. Others we depend on as food for our tables. Other germs are dangerous. They are pathogens. What are pathogens? They are germs which produce infection and disease. They are the ones we have to be concerned with. How are these infectious germs spread? Let's take a look. There are three things which must be present for infection to spread. There must be a source of the infection, a means for the infection to be carried from one place to another, and a person who is in a weakened condition to catch the infection. Sources include people who are coming down with an infection, people who are at the peak of an infection, and people who appear healthy but are carriers of disease, such as AIDS, tuberculosis, or hepatitis. Other sources include animals, food, and objects which have been contaminated by infected people or animals. There are 4 ways in which infection is carried from one place to another. The first is through contact with the infected source, either by direct contact, indirect contact, or through droplet spread. Germs can be carried as far as 3 feet by this method. The second way infection spreads is through the vehicle route. This means that germs are carried by other things, such as spoiled food, water, drugs, or blood and other body fluids, as in the case of urine or mucus. The third way it spreads is through the air. This occurs when the germ remains suspended in air for long periods of time while attached to dust in the air, or on droplets of moisture. They are then easily inhaled or deposited on other people or objects. An example of this is Legionnaire's disease, where infectious germs attach themselves to cool moisture in air conditioning ducts and misters, and then are inhaled into people's lungs. The last way infection is spread is known as vector-borne. Insects, such as ants and mosquitoes, carry diseases from one place to another. Malaria is a good example of a disease which is vector-borne. It is caused by the bite of a mosquito. Everyone in contact with an infectious disease does not automatically get an infection. There must be something about the person's health or condition which makes him susceptible. There are some common things which make people susceptible. Age, especially the elderly and the very young. Medical conditions, such as diabetes or emphysema. Breakdown of the skin from cuts or pressure sores. Lack of immunity to or defense against certain diseases, for example, AIDS or chickenpox. And some medical treatments, for example, those used to fight cancer. As caregivers, we have a responsibility to prevent the spread of infection to our clients, other people in contact with the client, and ourselves. We can do this by not allowing the 3 elements to come together. How can you control the source of infection? Don't take an assignment if you have an infection. Discourage visitors who show signs of having something which the client may catch. Keep garbage in closed containers and dispose of it properly to stop rats and insects from being attracted to it. Handle and prepare food appropriately to destroy any germs which may be present before cooking. Be sure to store foods in closed containers to keep bugs and other pests out of them. and refrigerate food as soon as you are done with it, if it is supposed to be kept cold. Be sure to clean up dirty dishes and work areas immediately if possible. Keep doors and windows closed, unless they have well-maintained screens on them. Way of finding the smallest openings to get into a house. What can you do to prevent the spread of infection? There are 4 major ways that you can do this. The first method is by hand washing. This is probably the simplest and quickest way to stop the spread of infection before it starts. When should you wash your hands? Before and after care of your client, before and after preparing food, before eating, after using the toilet, and any time you feel you have handled something which is dirty or may have unwanted germs on it. How do you wash your hands correctly and effectively? Turn on the water and adjust the pressure and temperature so that it is very warm but not burning hot. Wet and soap the hands thoroughly, lathering the back of the hands, the palms, wrists, forearms, and between the fingers. Run water over the soap to clean it. For stubborn dirt, use a brush to scrub your hands if necessary. To clean between the fingers, interlace them and rub up and down. Clean around and under the fingernails. Rinse with your hands hanging down into the sink so that the soap, dirt, and oils will drain off the fingertips into the sink. Repeat the whole procedure again before drying. Do not turn off the water yet, however. Dry your hands thoroughly using a clean cloth or paper towel. It is recommended that whenever there is known infection, paper towels should be used instead of cloth so they can be disposed of. Now turn the water off using the towel to avoid getting the germs you left on the faucet back on your hands. Throw the paper towel into a covered container. Hang the damp cloth towel up to dry. Use a hand cream or lotion to avoid dry skin. Remember, your hands carry many germs, so keep them away from your face, especially when you are working around a client with an infection. The second method is proper disposal of infected wastes. What do you do with them? First, pick up any soiled waste using tongs, spring clothespins, tissues, or paper towels. Use gloves if necessary. Depending on the type of soiled waste, you can put it into 2 thicknesses of newspaper. Wrap it securely, and then put the newspaper into either a plastic or paper bag, close it securely, and then place it in a covered garbage container. If a garbage disposal unit is available in the sink, you can put uneaten food or liquid into the disposal and then flush it with a 1 to 10 disinfectant solution. We will tell you how to make this solution shortly. Liquids can be flushed down the toilet, as well as bodily secretions including urine, bowel movements, vomitus, blood, or sputum. This should be followed by flushing the toilet again with the disinfectant solution. Containers which are used to carry bodily secretions should be washed out with warm, soapy water, rinsed with 1 to 10 solution, and then rinsed with clean hot water. Clients should put soiled tissues in paper bags which have been placed within their reach. Turn down a cuff around the top of the bag so your fingers can be placed under the cuff when closing it. To dispose of it, close the bag and put it into a second bag. Close the second bag securely and then place it in a covered garbage container. When you are finished getting rid of the soiled waste, wash your hands as we have described to you. Although extra care is taken in the disposal of infected wastes, you should use similar care when there is any suspicion of infection, or in the case where the waste product is an excellent place for germs to grow, such as on leftover food which is not refrigerated. The third way you can stop the spread of infection is by disinfecting areas and articles in the home which become contaminated from use. To make a disinfectant solution, mix 1 part of bleach into 10 parts of water. For example, put 1 cup of bleach into 10 cups of water. Be sure that the container you are using is clean by rinsing it out with hot water beforehand. Never mix anything with the bleach except water. Mixing bleach and ammonia, for instance, can produce a dangerous gas which can make you or your client very ill. Before you can do any disinfecting of an area, you must dispose of any soiled waste as described above. Sponges and cleaning cloths used to clean the floor or to wipe up any body fluids should not be used to wash dishes or clean food preparation areas. Dishes which are used by people with an infection can be used by others once they are washed in hot, soapy water and then rinsed thoroughly with hot water again. The water should be hot enough that you have to wear gloves to tolerate it. The dishes should be allowed to air dry in the dish drain. Do not use a dish towel. It is full of germs which you don't want back on the clean dishes. Bathrooms should be cleaned regularly using the disinfectant solution. Clean up the area first with warm, soapy water. Rinse with clean water, and then wipe again with the 1 to 10 mixture of the bleach and water. Rinse once more with clean water. This same mixture can be used on the floor, sink, toilet, tub, and shower. The bathroom floor should be cleaned at least once a week using the disinfectant mixture. Anytime something which may carry infection gets on the floor or bathroom fixtures, such as urine or blood, it should be cleaned up immediately with warm, soapy water and then disinfected with the bleach solution. Mop water should not be poured down a sink where food preparation takes place. Sponges, cloths, or mops which are used on the floor or to wipe up non-food spills should not be rinsed out in the sinks used for food preparation. These sponges, cloths, and mops should be disinfected after you are finished with them by putting them into the 1 to 10 disinfectant mixture for 5 minutes. Do this in an area not used for food preparation. When you are all finished, wash your hands as we have demonstrated earlier. Be sure to use hand cream or lotion afterwards, so your hands do not become dry or cracked. Small cracks in the skin may develop which open you up to infection. This infection can then be spread to others. Linens and clothing which have been soiled must be cleaned thoroughly to prevent the spread of infection. Before they can be cleaned, however, you must remove as much of the soiled waste as possible. Use the procedures we told you about earlier in this tape. When removing linens, handle the cleanest parts only. Fold the linen into the center to contain the soiled area. Do not shake out the sheets. This fills the air with the infectious germs. Carry the soiled linen away from your body and clothing, and place it in a laundry bag or a clean pillowcase. Put it into a plastic bag if it is being taken to the laundromat. The first bag should be washed with the linen, and the plastic bag should be disposed of in the covered garbage container. Do not use this second bag to bring the clean clothes back to the clients. For laundering in the home, soak heavily soiled linens in bleach and detergent for 10 minutes before washing. Follow the directions on the bottle for the amount to use. Be sure the bleach and water is well mixed before you put the linens into it. Then wash them in the usual manner. But put them through a second rinse if you can to remove any possible germs which may still be present. For disinfecting soiled clothing, add 2 tablespoons of Lysol-type disinfectant to each gallon of water, along with the laundry detergent. Read the directions on the bottle for the amount to put in if you are using a washing machine. Rinse the clothing at least 3 times if washing by hand. Your hands should be washed as demonstrated after you have handled the soiled linens. Laundry facilities should be flushed or rinsed with the 1 to 10 disinfecting solution we described previously. If you are at the laundromat, wipe out the washing machine afterwards with the 1 to 10 solution or the Lysol disinfectant. Do not wash the soiled clothing or linens in the kitchen sink. If you have no other choice, use a basin which has been labeled specifically for that purpose. Dump the wash water down the toilet and be sure to disinfect the sink, basin, and toilet with the 1 to 10 solution when you are finished. When you are all done, wash your hands and apply a cream or lotion to prevent dry skin. The fourth way to stop the spread of infection is by using protective barriers when necessary. At certain times, you should wear protective items to keep an infection from spreading to you. Your nursing supervisor will tell you when this type of protection is needed. These items include masks, gowns or aprons, and gloves. Masks may be worn when giving care to a client who has a respiratory infection which results in uncontrolled sneezing or a productive cough. Gowns or aprons may be worn when there is danger that an employee's clothing will be soiled by body fluids, blood secretions, or excretions. Gloves may be worn when handling blood-soiled articles, specimens, secretions, excretions, or any surface material and objects which may have been exposed to them. This list is a sample of the times protective barriers are used for patients with diseases carried through the blood, as in AIDS and hepatitis. You will notice that there is only a few times when gloves are needed. And almost no time when gowns, masks, or protective eyewear are needed. Gloves, gowns, aprons, and masks should be of the disposable type. When removing gloves, try not to touch the contaminated surface with your bare hands, and pull them off so they are inside out once removed. When taking off gowns and aprons, take a hold of them in the clean areas only, usually around the back, and fold them in on themselves so they are also inside out once removed. They are then double bagged, just like the other infected wastes, and placed in a covered garbage container. Don't forget to wash your hands. if you have any questions about using protective barriers with a patient. Your nursing supervisor will tell you if you need to or not. One other thing you should remember is that the germs you are exposed to in the home of a client with an infection are not left there when you leave. Some of them follow you home on your clothing, shoes, and skin. It is recommended that you always change out of your work shoes when you leave the client's home. Keep your soiled work clothes in their own laundry bag while waiting to be washed. You should wash them as soon as possible to reduce the amount of time the germs have to multiply and spread to your family. Wash your work clothes alone, not with your regular laundry, and use the same disinfecting procedure you use for your client's clothing. Always wear freshly cleaned clothing when you go to work. And be sure to wash up well before you leave work, so you won't infect your family. The third element in the spread of infection is the susceptible host. What can you do to reduce the chances of the client being in a weakened or susceptible condition? Some things you can do are: be sure they eat well-balanced meals. Keep them moving. Do not let them stay in one position for more than 20 minutes at a time, unless they're sleeping. And even then, check to see that they have not stayed in one position for more than 2 hours. Be sure they are positioned properly for good breathing and circulation. Make sure they take the medications that have been poured for them. Try to provide them with a good combination of rest, physical activity, and mental activity. In summary, provide them with a great deal of tender, loving care. And don't forget yourself. You can be susceptible too. Eat well. Maintain a good combination of rest, physical activity, and mental activity for yourself also. And don't take chances with your own health.
Okay, I want you to roll over towards me. You can help with your arm, and I'm going to help with your legs, okay?
Okay. Bend your knees a little bit. As a person who helps others, you are often asked to do things which require moving, bending, and lifting.
Okay, ready?
Several things can happen if you do not do this right.
How about one more time?
You can be exhausted from doing them. You can get hurt, or you might hurt someone else. The right way to move, bend, and lift is through the use of good body mechanics. The same principles apply whether you are moving an object or a person. We will start by explaining more about good body mechanics and then demonstrate how it is used during reaching, stooping, pushing, pulling, and pivoting, while lifting and carrying objects, and while moving a person. First, let's define what good body mechanics is. Your body is made up of many bones, muscles, and ligaments, which work together as a system of levers, much like a machine. When you take advantage of these systems of levers and use them efficiently, you are able to move, bend, and lift with a minimal amount of effort and strain. This is good body mechanics. There are certain principles of movement which, when followed, will make you use the levers at their highest level of efficiency. The more efficient you are in taking advantage of these levers, the easier your work will be. Let's look at an example of a mechanical lever to help you understand just what levers are and how they work. Think back to when you were a child and you used to play on a seesaw. The seesaw was a lever. It was used to lift you and your friends up off the ground one at a time. If you or your friend were both about the same weight, then you could ride smoothly as long as both of you sat at the two ends of the board. What happened when you moved closer to the center? The person at the far end quickly dropped down as if all of a sudden she was heavier than you. The closer you got to the center support, the faster she went down and the lighter you became. What a way to lose weight. Unfortunately, your weight really didn't change, it only appeared to. What really happened? The overall force needed to raise and lower you and your friend varied, depending on two things. One, how much each of you weighed, and two, how far you each were from the center support. Say you both weighed 40 pounds and were both 4 feet from the center. The weight times the distance would tell you the force needed to lift each of you up. You would each be exerting 40 times 4, or 160 units of force. Because it was equal, you could balance in midair without your feet touching the ground. If you took turns pushing off the ground, you could move up and down easily. When you moved halfway up the board, so you were only 2 feet away from the center, your friend still was at 160 units of force, but you were now 2 times 40, or only 80 units of force. You were only exerting half as much force, so you went up in the air, while your friend quickly dropped down. What about levers in your body? They work very much the same way. Your back is a lever which can become a very strong center support when locked into one position, or a very weak series of levers if used improperly. Your arms are levers, as are your legs. You are made up of a built-in system of levers which can be used just like the seesaw to move objects up and down. How does this all relate to using good body mechanics? When you are trying to move or lift an object or person, the closer you carry it to your body, which is the center support, the lighter it will appear to be, and the less force will be needed to move it. This brings us to the principles of good body mechanics. What are they? Keep the weight being moved close to your body. Just as when you were on the seesaw, the closer the weight was to the center support, the less force was needed to move it. By carrying the object close to your body, you put less strain on your back and will not get tired as quickly as you would otherwise. Keep your feet positioned to give you a wide base of support. The more stable the center support is, the less effort it takes to move the object. Imagine if the seesaw had only been on a narrow support which swayed from side to side. You would not only have needed force to make it go up and down, but you would also have needed force to keep it from tipping over. This would have made it a lot harder for you to enjoy yourselves. Avoid twisting motions during lifting. While twisting, you are not able to fix your back in one position to make it a strong center support. As a result, the center support is not stable. More force is required, and you risk injury to your back because of it. Use your arms and legs to do the work rather than your back. Your legs are strong for lifting, and your arms are flexible for moving objects in close to you. Your back can be locked to make a strong center support. When you use your back to lift, you not only have to lift the weight of the object you are trying to move, but also 2/3 of your own body weight. Your low back becomes the center of support. If you weigh 120 pounds and are lifting a 20-pound box, you could be asking the muscles of your low back to lift the 20 pounds plus 80 pounds of your own weight. The force needed reduces as the distance from the center support reduces, but this is still a lot of strain on the low back muscles. If you lock your back and lift with your legs while bringing the box close to your body, you are essentially lifting only the 20 pounds. If you don't move it close to your body, you then have to add the weight of your arms to the 20 pounds and multiply it by the distance away from your body, just like we did with the seesaw. If you don't believe this, try bending at the waist and lift a book up so it is level with the floor. See how long it takes before you get tired from the weight of the book. Try the same thing while you are sitting up straight. And lastly, try just bringing your arms up over your head while you are sitting. Can you feel the difference? Push or pull heavy objects whenever possible instead of lifting them. That way you only have to overcome the friction between the object and the surface you are moving it on, rather than having to pick up the full weight of the object and balance yourself while doing so. Be sure to use your legs and arms rather than your back, however. Work in the direction of the movement. It reduces the amount of twisting you will do. It also puts less strain on your back if you move your feet or you shift your weight from one foot to the other. And finally, work at a comfortable level. Being in an uncomfortable position over a period of time produces strain on your back and neck, discomfort, fatigue, and eventual injury. Whenever possible, adapt the situation so you can make use of good body mechanics. Now, let's see how to put these principles to work for us. First, we'll look at body movements, which are a part of almost everything we do throughout a day. We'll start with reaching. The first thing you want to do is bring the object closer to you. If it is over your head, get on a step stool or ladder so you are closer to it. If it is on the same level as you, slide it over until it is as close to you as possible. If it is below you, bend at the hips and knees to lower yourself down to it. Do not bend over with your back to get closer. You want to be sure your feet are in a good position to give you a wide base of support and mobility. If you are on a ladder or step stool, be sure you are reaching out in front of you. If you are in too close and have to reach straight up, you could lose your balance backwards. If you are on the level, put one foot in front of the other, so you can shift your weight from the front foot to the back foot as you draw the object closer to you. Do the same if you are reaching below waist level. Be sure you are facing the object you are reaching for so that you do not twist as you pull it towards you. By having your feet positioned one in front of the other, you can lock your back and partially lock your arms so your body weight will pull the object towards you as you shift your weight onto your back foot. If you are on a ladder, you can't do this, but you can stabilize yourself by leaning against the ladder while your arms do the pulling. Do not lift the object until you have slid it close to you and you are in a comfortable and stable position for lifting. Next is stooping. You do this when you have to wipe something up off the floor or get items off the bottom shelf of a cabinet. Bend at the hips and knees, keeping one foot in front of the other. Keep your back as straight as possible. Once down, Keep the weight on your front foot and balance on the ball of your back foot. This helps you balance better and enables you to shift your weight as you do the task. When you are getting up, keep your back straight and raise up using your hip and thigh muscles. If this is difficult for you to do, especially as you get older, do not hesitate to keep something nearby which you can lean on with your hands to help you get up. Next is pushing. Make your legs do the work by locking your back and fixing your arms in a bent position, and then lean into what you are pushing. Pulling is next. If you have to pull something, be sure that you are not twisted while you're doing it, and that you are using your arms and your legs rather than your back. Pivoting is the last body movement. Pivoting will help you avoid twisting your back. You do this in two ways. One, by placing your feet so one is facing where you're starting from, and one is facing where you are going. The second way is by taking small steps in place as you pivot. Now let's look at the actual lifting and carrying of objects. You should use all of the principles of good body mechanics we have discussed so far. In addition, you should plan ahead by knowing your own limitations and the limitations of the areas you are working in. Test the weight of the object before you pick it up. Think about how you are going to lift the object and what you are going to do with it once you have it. Have a place ready where you are going to set it down before you lift it. And be sure that obstacles are out of your way. When you pick up the object, use both hands and try to grasp it as close to the center of gravity as possible so it is balanced. If you are carrying it any distance or amount of time where you start to feel discomfort, shift the object from side to side periodically to reduce the strain. If you find the object is too heavy once you have picked it up, set it down and try something else. And finally, let's look at moving people. Everything we have talked about so far also applies to moving people. There is one major difference, however. You are working with living, flexible human beings who also have minds of their own, so they can either help you or hinder you as you try to move them. At some time, you may have to move a client in bed. You most likely will have to do this alone. To move the patient closer to the side of the bed, slide your hands and arms under the client's head and shoulders and pull her toward you. Be sure your knees are bent, that you do not twist, and that you use your body weight to pull the client. Do the same for the lower half by sliding your hands and arms under the client's hips and then under her legs. Also be sure that the client is not holding onto something which will prevent you from moving her. If the bed can be raised or lowered, raise it to the height which is most comfortable for you. Have the head of the bed flat if the client can tolerate it. If the client can help, have her do as much of it herself. You may still want to have your hands and arms under her hips to reduce the amount of friction against the skin as she slides over. From this position, you can assist the client in turning onto her side. To move her up in bed, be sure that the bed is flat. If the client can help, have her bend her knees and dig in with the soles of her feet. If she can assist with her arms, have her try to push up with her hands and forearms.
Scoot. Okay, bend a little more. Okay, scoot. Good.
Or push herself up by grasping onto the head of the bed. Instruct her to work with you by moving on the count of 3. You should be bent at the hips and knees with your back locked. Your feet must be turned slightly facing the foot of the bed, so when you do the lifting, it is with your legs rather than your back or arms. You also want the client close to the side of the bed when you go to help her sit up.
side, okay.
Slide your one hand and arm under her neck. Slide your hand down to the back of her knees. Let her legs hang off the side of the bed, and gently assist her to a sitting position. Continue to support her at the neck and shoulders until she has her balance.
Okay.
From here, you can transfer the client into a chair or take her for a walk. Let's look at chair transfer first. Before you have even moved the client to the side of the bed, you should have placed the chair within easy reach. Once the client is sitting up, position the chair so the side of it is against the bed, while you continue to support her if necessary. Whether you place it facing the foot of the bed or the head of the bed will depend on the client. You always want to move a person toward her strong side. If the person has a weak right arm or leg, you would want to place the chair so she moves to the left. Suppose the client has had her left leg amputated. You would want to place the chair on the right. Do not make the common mistake of facing the chair toward the bed. When you go to transfer the client, you'll have a lot of floor to cover before you can sit her down. And you'll have to support her twice as long as you would if you had placed the chair next to the bed. If you are putting the client into a wheelchair, be sure to lock the brakes. Depending on the client's strength, balance, and abilities, there are several things you need to do. First, you want to give support wherever necessary if she is having trouble maintaining her balance. Next, you want to position her feet so they will be under her when she stands up. You may have to lock them into position with your feet to keep them from sliding. Bend your knees and lock your back. Be in a position to use your knees to help the client straighten up if necessary, or to prevent them from buckling if that should happen. You do this by hugging her knees with yours so that you are just slightly off the center of her knees. The client's upper body should be brought forward over her knees before standing. If she can't do it herself or tends to push back, place one of your hands behind her neck and gently hold her forward as you both stand up. Get in close to the client. If her trunk balance is good, take a hold of her belt and help lift her from there. If it is not, or there is no belt, wrap your arms around her lower rib cage and lift from there. If the client can help, have her rock forward several times and then push up on the count of 3. If the client can't help pushing up, she may be more comfortable and secure if she places her arms over yours in a light hug to help get closer to you. As you stand her up, remember to use your knees to help support her knees. If possible, bring her to a full standing position, allowing her to bear weight on her own legs. Pivot by taking small steps as you turn to avoid twisting. And then gently lower her into the chair, bending your hips and knees as you do so. For getting the client back into bed, you would follow the same procedure in reverse. Sometimes while a client is sitting in a chair, she may tend to slide forward and cannot get herself back. There are 2 ways to help her back, which require very little work from you. One is to help her lean forward by placing your hand behind her neck and then have her push back. The other is to stand in front of her with your knees touching hers. Bring her forward as you did before. Place your other arm around her lower rib cage, lean back as you lift her slightly, and at the same time give a quick push with your knees. There is one other way to move a person back in the chair, but it requires more effort on your part. That is by getting behind the chair and lifting. If you must do this, be sure to lean the client forward. Grasp onto the client's wrists, and then lift by straightening your legs. As you have noticed, we have made use of all the principles of good body mechanics while moving the client. These same principles are used when assisting the client in walking. If the client does not need a cane or a walker, but does need supervision or a little support, there is a correct way to do it. First of all, stay close to the client without being in her way. Place your hand which is closest to her lightly on her back at the waist. Have your other hand lightly in front of her upper arm, or at least be prepared to move it if she loses her balance. You vary the amount of support and contact depending on the client's needs, including having her pulled in against you if extra support is needed. As you walk together, be sure to time your steps with hers, stepping out with the left foot when she steps with her left foot, and the right foot when she steps with her right foot. Doing this has two effects. One, it helps her balance. If you step with opposite feet, you bump hips and throw her off balance. And two, it keeps you in a good position to prevent injury to either of you in case she starts to fall. If you are on the opposite foot, you are turned away from her and will be twisted if you go to help her. This will result in you injuring your back and her falling. Always just step two with your inside foot. Do not step ahead with it. This way you are never turned away from the client if she loses her balance. You do the same thing when the client uses a cane. Make sure that the cane is not placed too far out in front. It could slide out from under her if she leans on it. If she is using a quad cane, be sure that it is placed flat on the floor before she leans on it, and that the legs which stick out the furthest are on the outside. When using a walker, you want to support the client the same way, except you may have to place your hand on the crossbar of the walker instead of in front of the upper arm if the client does not control the placement of the walker well or tends to tip backwards. Be sure that the walker is brought forward only enough so that all four legs are flat on the floor when she leans on it. To reduce the chance of the client tipping backwards, make sure that she does not step too close to the walker. There should always be about 5 inches between the client's body and the crossbar. If the client ever starts to fall and you can't prevent it, just gently lower her to the floor to prevent injury, and then decide what to do from there. Well, we have covered a lot of information and demonstrated many skills. You will have to practice these skills and the principles of good body mechanics in order to become completely familiar with them. Let's just briefly review what you have seen. First of all, we said that the right way to move, bend, and lift is through the use of good body mechanics. We defined good body mechanics as taking advantage of our built-in system of levers to help us move, bend, and lift. We demonstrated how a lever works, and then discussed the principles of good body mechanics. And lastly, we demonstrated how to use good body mechanics in reaching, stooping, pushing, pulling, pivoting, lifting and carrying objects, and moving people. In summary, you can see that using good body mechanics will help you in your job of caring for other people. You will be less tired because you have done less work. You will avoid injury to yourself, and most importantly, you will have prevented injury to your client. An accident is about to happen. Can you feel it? You've got to stop it. Where do you begin? There's so much to do. But you can do it. You're a home care worker. As a home care worker, you take on a very important responsibility. You must ensure the safety of your client, both when you're on the job and when you're not. This is not as hard as it seems, however. We would like to spend the next few minutes taking a look at what the most common home accidents are, the potential hazards which cause the accidents, and what you can do to prevent them. In the second half of this program, we would like to show you what to do if an accident or emergency happens. This will include simple first aid techniques, emergency procedures, and what to do in case of a fire. We'll start with common home accidents. The most frequent ones include falls, burns, cuts, poisoning, choking, and electrical injury. Young children and elderly people are the most likely to become the victims of these accidents. One reason for this is because they both have balance problems. They are also more easily burned because of sensitive skin. Elderly people may also have hearing and vision problems, reduced sensation, mental confusion, and possibly some effects of medications which may cause problems. Young children have a natural curiosity which makes them always want to touch, taste, and try things. They have very little or no fear because of the lack of experience. There are hazards which exist in every room of the house, and you as the home care worker must be aware of potential hazards and do something to eliminate them. You should get in the habit of looking for hazards on your very first visit to a home, discuss them with your client and supervisor if necessary, and then be sure it is corrected. Each time you return to the client's home, you should check for hazards again and try to encourage the client to participate in keeping the home safe. The kitchen is the most hazardous room in the house. There are many sharp objects to be found there. The potential for broken glass is always present. Burns can occur from touching hot surfaces, knocking over hot liquids, splattering of hot grease, or starting clothing on fire from getting too close to an open flame. Gas may leak from burners which have gone out on the stove and cause an explosion or asphyxiation if it goes out unnoticed. The kitchen is most frequently the place where hazardous household products are kept. Overloading outlets with many small appliances is not uncommon, as is the use of small electrical appliances near water. Storage of items in upper cabinets produces two hazards. They are difficult to reach and may fall on a person, causing injury. Wet spots on the floor are slippery, and throw rugs may slide or cause someone to trip. There is an old saying which states, "The best cure is prevention." For the safety of your client and yourself, you must continuously be on the lookout for potential hazards and do something about them. What can you do to make the client's kitchen safer? Point out hazards to the client and discuss how to eliminate them. Be sure that sharp objects are stored properly. When using knives, always cut away from you. Keep your hand dry and free of grease when using the knife so it doesn't slip. Store glass objects neatly. Dry your hands before picking up glass. If you have to pick up broken glass, use something which is padded to do so. For smaller splinters, use several thicknesses of wet paper towels. Place the broken glass in layers of newspaper, roll it up gently, and put it in a paper bag, and then into the garbage. Remember, never push garbage down in the container with your hands. Prevent burns by using pot holders and hot pads. Be sure you know where they are before you start cooking, and keep them handy. Keep pot handles turned toward the back of the stove. And always place hot containers on a level, secure surface, away from where people can knock them over. Do not overheat fats and oils. Splatter can cause burns or start a fire. Encourage the client to get an ABC fire extinguisher for the house, and keep it in a place where it is readily available. If one is not in the house, keep a pot cover or lid next to the stove, and know where the baking soda is in case of a grease fire. Do not reach across open flame, especially with loose-fitting clothing. Check to see that gas burners remain lit when you have the gas on. When finished cooking, double-check to see that the gas is shut off. For people with poor vision, it is helpful to mark the off position with red nail polish. Be sure that household products are stored away from food. If there's a small child in the house, be sure these products are stored out of reach of the child or in a locked closet. Do not store them on top of appliances where they can be knocked down and spilled on someone. An electrical outlet is only equipped to handle 2 plugs at a time. Keep it that way. Never plug in 2 heat-producing appliances into the same circuit, or use extension cords. Unplug small appliances when not in use. Use extreme caution when using an appliance near the sink. Be sure the work area is dry, including the floor. Store the most frequently used items at eye level. When getting items from high places, use a step stool designed for climbing on, not a chair which may slip. Older people should not tip their heads back to look at a high object through the bottom of their bifocals. This can cause dizziness and result in a fall. Wet spots on the floor should be cleaned up immediately. A rubber-backed mat in front of the sink helps keep the floor drier. Be sure throw rugs have non-skid backs, or are taped down with 2-sided tape to prevent them from slipping. Bathrooms are the second most hazardous areas in the house. Floors and tub bottoms are slippery, especially when wet. Electrical appliances are used near water. All surfaces in bathrooms are hard and have projecting fixtures, which may be hazardous in case of a fall. Medications are usually stored here. Scalding can occur from water which is too hot. How do you reduce the chance of an accident in the bathroom? Cover floors with non-slip mats or wall-to-wall bathroom carpeting. Wipe up water on the floor immediately. Use non-slip mats in the bathtub. Have grab bars installed around the tub and toilet. Try to encourage the client to use electrical appliances, such as razors or hair dryers, someplace other than the bathroom or kitchen. If you can't convince them to do this, be sure there's no water in the sink or on the floor when they are using them. Keep a nightlight on in dark bathrooms. Sit on a shower bench when showering if balance is poor. Store medications in a closet or drawer outside of the bathroom. Moisture and temperature changes are not good for medications. If a small child lives in the house or frequently visits, keep the medications out of reach and in a locked area. Keep hot water tank temperatures between 110 and 120 degrees to prevent scalding. Clutter any place in the house increases the risk of an accident occurring. This is especially true on the stairs or in narrow hallways. These areas always seem to collect things which we meant to put away. This clutter is not only dangerous because someone may trip on it and fall, but also it makes it more difficult to escape through these areas in case of a fire. Lighting is frequently poor in stairwells, increasing the hazard. Some stairways have no handrails or have ones which are no longer safe to use because they are loose. The top of the stairs is particularly dangerous for a young child, since they can be seriously injured if they fall down the whole flight of stairs. As the home care worker, you have the responsibility of working with the client to keep these areas free of clutter. If lighting is poor, use a stronger bulb if possible. Or talk with your supervisor if the lighting is still not good enough. It is not uncommon in older homes to find that the handrail in the stairway has become loosened. If it cannot be easily fixed, be sure to bring this to the attention of your supervisor so arrangements can be made to have it repaired. When working in a home with young children, be sure that there is some form of protective gate across the top of any open stairway. If there is carpeting on the stairs, be sure that this is in good condition. Rips in it can cause falls. Some steps may be slippery. Putting non-skid strips on the steps help reduce this problem. People with poor vision also have a hard time seeing the first step and the last step. A bright piece of tape on the top edge of the first and last steps helps people to see them. Make sure that it is a wide piece which sticks well and does not ravel at the edges. Be sure that there are no throw rugs on the top of the stairs which a person can trip on. Most of the hazards identified so far can also be found throughout the rest of the house. Be aware of them and take the same preventive measures we have discussed already. If space heaters are used in the home, keep them at least 3 feet away from everything, including people. Discourage the use of portable kerosene heaters. They give off carbon monoxide and use up the oxygen in the air, which can be dangerous to you and your client. Where there are smokers, deep, wide-rimmed ashtrays should be used. Or one with the holder in the center of the ashtray would be even better. Empty ashtrays only after ashes have been wet down. Never let your client smoke in bed or while taking medications which may cause them to be sleepy. If they must, stay with them the entire time. Encourage the use of smoke detectors and check them routinely to be sure that they are working properly. For your client's safety at night, if there is no smoke detector, encourage them to sleep with the door closed to keep smoke out in case of a fire. A telephone at the bedside is also a very good idea, along with a loud whistle in case they have to call for help. If there is a detector, have them keep the door open just a little bit so they can hear the detector if it goes off. Be sure that pathways throughout the house are kept clear of clutter. This could be very important in the case of a fire where these routes may be their only means of escape. If small children live in the household, place plastic child protectors into empty outlets so nothing can be put into them by the child. Be particularly alert to electrical hazards. These can cause severe burns, fire, electrical shock, or death. Some warning signs which you should look for: frequent blowing of fuses or tripping of circuit breakers indicates that a circuit is overloaded or shorting out. You should try to locate the problem and correct it if possible before you replace the fuse. Correction may be as simple as not having the electric coffee pot and the toaster in use at the same time in one circuit. If more complicated, contact your supervisor for further information. A feeling of tingling when you touch an electrical appliance could indicate wiring problems. Turn off the power at the fuse box and then unplug the appliance. Do not use the appliance again until it has been checked out by a qualified person. Cracked or frayed wires. If you see a wire which is cracked or frayed, shut off the power to the outlet at the fuse box, and then unplug the wire. Do not use it again until it has been repaired. A burning smell or unusual odor coming from an appliance or wire. Here again, turn off the power to the outlet before unplugging it. Place it somewhere away from anything else which might catch on fire, and watch it until you are sure that a fire will not start. Make sure that the client is aware of any of these problems, so that the client does not use the unsafe appliance or wire when you're not there. No matter how careful you have been, and how many preventive measures you have taken, an accident or emergency may occur. There are several things you should do before an emergency happens. Be sure you know what your agency's policies and procedures are in regard to accidents and emergencies before you go into a client's home. Each time you start working with a new client, make a list of important phone numbers and keep it near the client's phone so it will be readily available if you need it. The list should include your supervisor's number, a number for a relative of the client, and 911 if it is available in the community. If not, then the number of the police, fire, and emergency medical services should be included. On your first visit, you should also plan 2 different ways to get out of any room in the house in case of a fire, and make sure it works. Discuss this with your client, and every few weeks have a practice fire drill. Now, let's look at what to do if there is an accident or emergency. No matter how minor the situation appears, you must report it to your supervisor and document the incident according to the procedures set down by your agency. If your client gets injured and swelling occurs, apply a cold pack or ice wrapped in a towel to reduce the swelling. Then call your supervisor for further instructions. If the injury is to the head, call your supervisor immediately. For minor cuts and scrapes, assist the client in cleaning the area with water and applying a dressing or bandage if necessary. Minor burns usually cause redness or a small blister. Run the area under cold water immediately, or apply a clean, cold, wet cloth. Do not apply any butter, salves, or ointments. They tend to hold the heat in and cause more damage. In both cases, call your supervisor about the incident in case additional care is needed. If your client has a dizzy spell, you want to get the blood back to the brain as quickly as possible. If it happens while walking, gently lower him to the floor and then lie him down, or sit him down and bend him over so his head is over his knees. Again, report this to your supervisor. What should you do when more serious problems happen? In all cases, you must think before you act, for your safety and the safety of your client. Assess the situation. Did an electrical razor fall in the sink? Unplug the razor first and then pick it up. If you don't, you could be electrocuted. Assess the victim. If he is not responding, having trouble breathing, or in pain from a fall, call for help, being sure to stay calm. State the problem clearly, give the correct address and phone number, and identify yourself. Now for your very important first aid. This is the help you give before the professionals arrive, the help which can mean the difference between life and death in some cases. Choking usually happens when something gets stuck in the throat, such as food, candy, or gum. It may appear as if the person is having a heart attack. In the case of choking, the person cannot speak and quickly loses consciousness. A person with a heart attack usually is able to speak until they become unconscious. When a person starts to choke, encourage them to try to cough. If that does not work, then you should use the Heimlich maneuver. To do the Heimlich maneuver, you first ask them, "Are you choking?" And if they cannot breathe, cough, or speak, then you go behind them. Wrap your arms around their waist, make a fist with one hand, and place it with the thumb side against the victim's stomach, right in the middle, just above the navel, and well below the bottom of the ribs. Cover your fist with your other hand and pull back quickly with a thrusting motion. Repeat it if necessary until the object is released and the victim starts breathing again. If the person loses consciousness and is still not breathing, turn him on his side toward you. Look into his mouth. If something is blocking the airway, take 2 fingers and slide them down the inside of one cheek. Move across the throat, loosening the object, and then pull it up the inside of the other cheek and out of the mouth. Never go straight into the mouth to try to get the object out, because this may cause it to go even further down the throat. If you are not able to get the object out this way, turn the person on their back and give 6 to 10 abdominal thrusts, and then try the same procedure of removing it by hand as previously shown. Once the airway is clear, check to see if the person is breathing. If not, you must do the breathing for them by starting artificial breathing. To do this, put one hand under the neck and the other on the forehead, and tilt the head back. Check for breathing by looking for the rise and fall of the chest. If there is still no breathing, pinch the nose shut with the hand that is on the forehead. Take a deep breath, open your mouth wide, and cover the victim's mouth with yours. Give 4 quick, full breaths as fast as you can. This quickly fills the lungs with a lot of oxygen. Again, check for breathing. If you have had trouble getting air in, reposition the head by tilting it back again. If the victim is an infant, give only 4 quick puffs through the mouth and nose, and do not tilt the head back as far as you would for an adult. If the victim still does not start breathing, give 1 deep breath every 5 seconds for adults, or 1 gentle puff every 3 seconds for an infant, until breathing resumes or professional help arrives to take over. If the heart has stopped beating, cardiopulmonary resuscitation, or CPR, should be started on the victim. It is not recommended, however, that you do this unless you have taken the certification course for CPR. Ask your supervisor for more information about this. If a person has a severe amount of bleeding from an injury, you must get the bleeding under control. To do this, put firm direct pressure over the area which is bleeding. Use a clean cloth or dressing, or your hand if you must. Wear disposable gloves if readily available. If the cloth or dressing gets soaked with blood, add more until the bleeding is contained. Do not remove the bloodied pad. This would disturb the clotted blood and cause more bleeding. Keep pressure on it until professional help is available. If at all possible, place the bleeding part up so it is above the level of the heart. At no time should you put a tourniquet on to stop the bleeding. At no time should you give an unconscious or semi-conscious person something to drink to help wake them up. They may breathe in the liquid and damage their lungs. If you think that your client may have drank or eaten something which is poisonous, read the label on the container for first aid instructions. If there is a poison control center in the community, call them for help, or 911. They will want to know the name of the substance, who makes the product, how much was taken and when, what is the condition of the victim, and if you have done anything yet to help the victim. After following the directions, call your supervisor. If your client falls, especially if elderly, a serious sprain or broken bone may result. In this case, you should call your supervisor first for additional instructions before anything else. Do not move the injured area or attempt to move the person. You may cause more damage by doing so. Put a blanket on the person to keep them warm and prevent shock until professional help arrives. In the event of a fire, your first concern should be to get everyone out of the house. Once out, do not go back into the house for any reason. Have a pre-planned place to meet so you know if everyone is out. Call the fire department from a phone which is outside of the burning home. If the fire is in one room, get everybody out of the room first, then close the door to try to contain the fire. Smoke rises, so stay low, even crawl if you must, to stay below the smoke. Do not open any closed doors before first feeling them to see if they are hot. Use the back of your hand. In an electrical fire, if there is current to a metal door or doorknob, touching it with the front of your hand could make you clamp onto the knob involuntarily, resulting in burns or electrocution. If the door or knob is hot, there is fire behind it. Do not open it. Look for another way out. If it is not hot, open it carefully, but be ready to close it quickly if heat rushes in. If you are trapped in a room, try to keep smoke out of the room by stuffing cloth into the cracks where smoke is getting in. Go to the window and open it. Call for help by yelling "fire." Do not break the window unless you absolutely must. You may have to close it again if smoke or fumes start coming in from outside. Hang a white cloth out the window to help identify where you are when help arrives. If there is a phone in the room, call the fire department giving the location of the house and where you are trapped in it. Put a wet cloth over your nose if possible and stay in the window until help arrives. Keeping a jug of water in the closet of each room is a good idea, so it's there if you need it in case of a fire. In the case of a small fire which is not spreading, you should only use a fire extinguisher after you have called the fire department. If the fire is not between you and your escape route, if it is the right type of extinguisher, if it works, and you know how to use it. It is suggested that an ABC fire extinguisher be used in the house. The A type is used for wood, cloth, paper, upholstery, plastics, and similar materials. The B type is used on flammable liquids or gases, such as kitchen greases, paint, oil, kerosene, and gasoline. The C type is for electrical fires. The ABC type is good for any of the above. Always turn off the ignition source before trying to put out a fire. whether you use an extinguisher or not to do so. To use an extinguisher, remember the word pass. Pull the pin or lever, aim the nozzle at the base of the fire, squeeze the handle, and sweep the nozzle from side to side at the base of the fire. If you do not have a fire extinguisher, smother a grease fire with a pot cover, lid, baking soda, or dirt from a potted plant. Do not use water. This will spread the fire. If a cigarette starts a fire in a wastebasket, smother it quickly with something handy and large enough to cover the entire opening, and then put water on it. If clothing catches on fire, make the person immediately drop to the floor. Have them cover their face with their hands, keeping their elbows in, and roll them. This will smother the fire. If dropping to the floor is too difficult, take any large piece of cloth or clothing which is close at hand and smother the fire as shown here. Be sure to block the face with your arm and the cloth, and then smother the fire, stroking away from the face. No matter what the situation, be sure to call your supervisor as soon as it is safe to do so. In conclusion, as a home care worker, you have the responsibility of ensuring the safety of your client both when you are on the job and when you are not. You should be able to identify potential hazards through the house and work with the client to eliminate them. In the event of an accident or emergency, you should know your agency's policies and procedures for dealing with the problem, how to give the appropriate first aid when needed, and what to do in case of a fire. If you have any questions, be sure to call your supervisor.